Okay, so we're here. I'm here with Baxter, who apparently can't be restrained from being in this room. Um, we're here to finish up the second part of the anatomy here of the respiratory system, and that means that we're going to move then from the conducting zone where we started before, now here, eventually, maybe, now here into the respiratory zone, right? And again, remember we started off, we had just finished. Hi, Baxter. He had just started out, we've gone all the way down through to the terminal bronchioles, and now we're going to transition from those terminal bronchioles into the beginning of the respiratory zone, which are the respiratory bronchioles right here. The alveolar ducts are going to be the next part of that, and they're going to lead into, and we'll see this kind of in the next slide here, the sort of pouches of very, very thin, delicate tissue, which are the alveolar sacs. The alveolar sacs themselves contain the alveoli, and those alveoli are where we actually exchange gases with the blood. So here we are, terminal bronchiole. You can see here lots of that smooth muscle, like we talked about before, no cartilage, right? Because we're at the very, very end of the conducting zone, and transitioning then off into these little pouches, right, of alveoli called the alveolar sacs. And if we go in a little bit closer here, and even that far in, but you can see that these sacs are actually full of little interconnected chambers. Those themselves are the alveoli. So the alveoli themselves, right, we can think of this as the respiratory membrane, right? It's very, very, very thin, about half a micron thick. The idea behind these being so very thin, right? Remember, this is simple squamous, the thinnest possible tissue that we can have. The idea behind that is so that gas exchange can happen quickly and relatively easily. The thicker those walls are, the harder it is to exchange gases and the longer it takes. And so we really want to maximize the rate of exchange. Simple as that. Now, the alveoli themselves are mostly made up of those simple squamous epithelial cells, right? We call them type 1 cells or type 1 alveolar cells. But there are also a handful of these cells in here called type 2. And what type 2 cells do are they make something called surfactant. And the whole point of, so here we are within an alveolus, and most of these guys here, these sort of tan ones, right? These are those type 1 alveolar cells. These sort of lime green ones here, there, those are the type 2 ones. And the idea here is that when we are at something this small, right, when we're zoomed way in, we're at a very, very small scale, different forces apply than they do at sort of bigger scales. And one of those forces is water tension, right? And you might be familiar with water tension from seeing like water striders on the surface of a lake or the sort of rim of fluid of water or beer or soda or whatever above a slightly overfilled glass, right? Just the bond between polar molecules, in this case water, that holds them together. Now at this scale, the danger is that water tension, those attractant forces, will actually cause this side of the alveolus and this side of the alveolus to kind of collapse in on each other, right? And be kind of brought together and stuck to each other. And if that happens, if an alveolus collapses, we don't have any room in there for air. We have no gas exchange, okay? So what surfactant does is surfactant breaks that water tension up, okay? It prevents the collapse of the alveoli under water tension. So actually a really, really extremely important thing for us in terms of maintaining ventilation. The lungs themselves occupy massive space inside the thoracic cavity, right? So we've got basically the lungs and the mediastinum in the middle. And everything else has to get crammed into that mediastinum. So your esophagus, parts of your trachea, your heart, okay, your vena cava, your aorta, all that crap gets stuck in the mediastinum, and everything else is all lung. Okay. Now with the lung, we've got a couple of different anatomical terms that we need to kind of cover here. One of these here is the root, okay? And the root, if we look here, so here's a transverse section here. So we're looking at the top of the lungs here. Have been removed, I guess I should say that. And we're looking down. And so here is the lung. This is the left lung right here, okay? And this spot on the lung where the primary bronchi, the pulmonary arteries, the pulmonary veins, all of these things are coming and going, that's the hilum of the lung, okay? Now, where things get a little confusing is that here at the hilum, we also have this root. And the root is essentially all of this stuff, right? So if you were to reach in there and you were to grab the primary bronchus, the pulmonary vein, pulmonary arteries, kind of put your hands around them like that, grab them like that, what you would have in your hand is the root. So they enter and leave the lung at the hilum. The root is the sort of the combination of those structures. So it's a little confusing, but that's what those terms end up meaning for us. On the outside surface of the lung, so facing the ribs, we have the costal surface. So if we see here, we've got, they're sectioned a little bit so we don't see them exactly, but this whole side, right, facing out towards those ribs, that's the costal surface out here. As for the lungs themselves, the internal parts, it's mostly alveoli, right? Most of this is going to be respiratory zone stuff. Everything else is what we're going to call the stroma. And we've used this term stroma before, right? It means basically the same thing it is here. It's just sort of the connective tissue supporting structure here of the lungs. In this case with lungs, the stroma is mostly elastic, which means that as we stretch the lung, it wants to step back, right? And that elasticity is actually going to be really important for us when we actually start using the lungs and talking about how they're going to work. Other bits of anatomy here that are going to be useful for us. We have the apex of the lung, the top of the lung. And as you can see here, it comes up surprisingly high, okay? So here's this guy's clavicle right here, right? So everything above your clavicle, you can feel your clavicle at home, right? Everything above that, right, you kind of consider your neck, right? But here we have the apex of your lungs all the way up in your neck. And so one thing that you may have experienced is going to the doctor, he or she may have put their stethoscope up here, kind of at the corner of your sternocleidomastoid here and your clavicle. They were hearing lung sounds at the apex of your lung, because it does come way all the way up. Here at the bottom, right, so sitting right on top of the diaphragm, we have the base of the lung. Right? And then within each of these lungs, we're going to subdivide them into parts called lobes. Now, if you remember from last time, right, we talked about them being asymmetrical, right? So the right side is bigger and has 3 lobes. So we have a superior, a middle, and an inferior lobe. And the left side, being smaller, has just 2, a superior and an inferior lobe. And separating the lobes, we have fissures, right? Little cracks, little crevices in there. We have an oblique fissure on both the left and right side, okay? And if we look at a lung here from the middle side, so here's the root, here's the hilum, okay? The oblique fissure on the left side runs kind of at an oblique angle. It starts here, comes down to the corner, separating the superior and inferior lobes. And we have that both here on the right side and on the left side. On the right side, because we have an additional lobe, we have an additional fissure. That horizontal fissure then is going to separate the superior from the middle lobe. And the middle and inferior lobes are separated by the oblique fissure. Over here on the left, the reason our left lung is smaller than our right is because our heart sits right here. So here's the thymus too, just for a reference point. Our heart sits right here, and if you remember, it is a midline organ, but it is cockeyed. The apex of the heart sits over here on the left side, and so it occupies a lot of the space that would normally be lung. And so to kind of give room for it, we have a cardiac notch. Here we see an anterior view. And then in medial view on the left side, we have this depression here where the heart would sit. That's the cardiac impression, this place where this heart actually resided within that. You can also see on the inferior lobe here a little impression here of the descending aorta, the thoracic aorta, also on that. In addition to our lobes that we've talked about here already, we also are going to subdivide each lobe into these bronchopulmonary segments, or just simply segments. Again, there's more on the right than there are on the left because there's more lung on the right side. There's 10 on the right, and anywhere between 8 and 10 on the left. And these are useful because they are basically discrete little packages of lung, right? They are divided by connective tissue. So if you have a issue with one of your segments, your bronchopulmonary segments, it can be completely removed without damaging any of the tissue around it. And then within these segments, we have even smaller subdivisions, these things called lobules. If we go here to the bottom of the lung, you can see each of these tiny little chunks, right? Each of these is a lobule. And those are really the smallest subdivisions that we can see. And that's where bronchioles are going to serve. Surrounding the lungs, like surrounding the heart, and as we're going to see in the digestive system, surrounding all of those organs are double-layered serous membranes, right? Serous here again because it's internal entirely, right? We're not exposing the outside of the lung to the outside world. So they're serous and not mucous membranes. Here with the lungs, these membranes are called pleurae, right? We have a parietal pleura. This is going to be on the thoracic wall itself. Remember, the parietal part is always on the body cavity. And a visceral part, or a visceral pleura, that actually sits on top of the lung itself. And just like we saw with the pericardium, right, there's a cavity, in this case a pleural cavity, and that pleural cavity is not full of air, okay, as we'll see, that's bad. It's in fact filled with pleural fluid. And just like pericardial fluid, right, it's there to provide lubrication, but it also plays a role in sort of keeping the lung inflated, right? The surface tension, the negative pressure inside this pleural cavity, actually pulls the lungs out and holds the outside of the lungs against the thoracic wall. It keeps them from collapsing. When we interrupt this pleural cavity, when we poke a hole in it, that's when we get lung collapse because we lose that negative pressure, we lose that surface tension, and the elastic stroma simply collapses the lung in on itself. So here again, back to the same old picture again, and now this sort of light colored bit that we're seeing here. Here we have the parietal pleura on the outside, the visceral pleura here on the inside, the pleural cavity in between, filled with pleural fluid. Now, as far as using the lungs themselves, right, this is ventilation, okay, and it's basically a two-phase process. Inspiration, right, so air comes in, then we have expiration where air goes out. Simple as that, right? Well, it's not entirely simple because we have to account for a lot of basic physics, so to speak. The way that your lungs are going to work is by changing the relationship between pressure inside the lungs and pressure outside the lungs, okay? And so what we're doing as we inflate or deflate, okay, is we're increasing or decreasing the internal pressure relative to atmospheric pressure, okay? And this is just the pressure of the air that we live in. So for us, you know, we're about half a mile up. Okay, if you live down in Hollidaysburg, you're closer to sea level, right? Generally speaking, the pressure that we experience is more or less 1 atmosphere, okay? And so we're going to compare all of our internal respiratory pressures to atmospheric pressure, which is usually 1, right? So a negative pressure then, or negative respiratory pressure, is going to be anything less than about 1 atmosphere, right? And a positive respiratory pressure is going to be anything greater than about 1 atmosphere. And 0 pressure is 1. So in order to figure this all out, we need to also understand a couple of smaller pressures. Okay, so we talked about atmospheric pressure on the outside, but we also talk about pressures inside. And so we have pressure inside the lung, right, which we're going to call intrapulmonary pressure, or P-pul, right? This is the pressure inside. And then we're going to have pressure inside the pleural cavity, right? So between the visceral and parietal pleurae. And this is always going to be negative, okay? This always has to be negative. There always has to be a vacuum here. This pressure always, always, always must be less than this pressure. If it's not less than this pressure, then we have a collapsed lung. This suction is what's holding this lung open. We can also talk about transpulmonary pressure, which is just the difference between intrapulmonary and intrapleural pressures. Again, as long as that is negative, we're good. So this intrapleural pressure, right, this is, again, all that's holding us between lung collapse. All right, this is all we've got, because your lungs are elastic, and so they're going to want to shrink down. And we've still got surface tension of the liquid inside the alveoli. Yes, we've got surfactant in there, but there's still surface tension. And both of those two things are going to try to shrink your lungs down. And the only thing that we've got, okay, is some kind of suction holding us up against the rigid costal margins of our thoracic cavity, holding us up against those ribs and keeping us from completely collapsing. So therefore, if we go back and think about this, right, if this intrapleural pressure is ever equal to pulmonary pressure, intrapulmonary pressure, or atmospheric pressure, your lungs will collapse. Okay? Everything else, as long as it's below that, we're going to keep that airway open and we're going to be happy. Lung collapse specifically is called atelectasis. Okay? It can be due to any number of different things. You can have plugged bronchioles. If you have plugged bronchioles, the alveoli can collapse, and so you can get a atelectasis that way. The one you're probably most familiar with is called pneumothorax. Pneumo here meaning air, thorax meaning your thorax. And basically what's going to happen here is you've punctured either the parietal or visceral pleurae. Usually it's the parietal pleura. And in doing so, you release that vacuum, right? You open that up. It's like opening a vacuum sealed anything, right? You get that rush of air in there. Well, that rush of air that goes into that pleural cavity no longer holds the lung open, and it collapses shut. So what we're going to need to do is we're going to need to seal that off, and usually by putting something as simple as saran wrap over it, honestly, to kind of make the seal back over it again, and then sucking the air out of that, getting us back to the vacuum with a chest tube. Ventilation then is going to be a sort of our alteration of pulmonary pressure versus atmospheric pressure. It's really what it comes down to, right? And the way that we're going to do that is by changing the volume of the lung. Okay, if we make the volume of the lung bigger, we lower the internal pressure. Right? If we pull down on the diaphragm, pull down on the base of the lung, we suck. Okay. And if we relax that, if we allow the abdominal cavity to push back up again, the elastic stroma to kind of collapse back in a little bit, then we make the lungs smaller, we increase pressure, right? And as long as we lower pressure below atmospheric pressure, we suck in. As long as we raise pressure above atmospheric pressure, we blow out. Inspiration is what we're going to call an active process. We require muscular activity to make this work. Okay. Primarily, we think about the diaphragm. Okay. But we also rely on the external intercostals. Now, the intercostal muscles are simply just muscles that connect one rib to the one above it and the one below it. Okay. The external ones, the diaphragm, those muscles contract, the diaphragm goes down. The external intercostals pull the ribs closer together. The ribs go up and out. Okay. Thoracic volume increases, pressure drops below atmospheric pressure, air flows into our lungs. Okay. And it flows into our lungs until the pressure is equalized. We can also undergo what's called forced inspiration, just simply taking a deep breath, right? So this can be caused by obviously vigorous exercise, right? Obstructive pulmonary disorders can cause this as well. And so we're going to bring in some other muscles, right? So the scalenes, sternocleidomastoid, pec minor, again, to continue to try to lift and separate the rib cage, right? And pull the outside of those lungs as far out as we possibly can to make as big of a volume in there as we possibly can. And so that's going to be mostly these muscles here. So we think about the diaphragm pulling down, right? Pulling the base of those lungs down. Here we've got the external intercostals. You can imagine it as these guys contract, right? They're going to lift the ribs up and out. Okay. Then for expiration, when you're just sitting there breathing, as you sit here watching this video, unless you're watching it at the gym or whatever, normally this is a passive process, right? All we have to do is just relax those muscles, right? You relax the diaphragm, you relax the intercostals, and what happens is the elastic stroma simply pulls the lung closed, right? As it pulls the lung closed, it pushes air out. Simple as that, okay? Now, just like with inspiration, we can have a forced expiration. And here we're going to add in a couple of extra muscles as well. So particularly the oblique and transverse abdominal muscles, the internal intercostal muscles, rectus abdominis to some extent. And here the idea, right, is that we're going to minimize the size of the thoracic cavity. So if we look at pressure relationships to breathing, okay, so typically the average breath takes about 5 seconds, right? From breathing in to breathing back out, we have about 5 seconds. And so as we go through this, right, in terms of the volume, right, we breathe in and we breathe out, okay? Now, while this is happening, breathing in, breathing out, we're experiencing changes in pressure, right, intrapulmonary pressure, relative to atmospheric pressure. So as we breathe in, pressure declines and then comes back to 0. We stop breathing in, and then we blow out, we increase pressure, and that comes back down to 0 as we stop breathing out. Importantly, okay, with the intrapleural pressure, right, this pressure in here, it is always, always, always less than the intrapulmonary pressure. This line never crosses this line, okay? When this line crosses this line, we have atelectasis, and that's bad. We're going to measure respiratory efficiency, respiratory status in a couple of different ways. One way that we can do that is with respiratory volumes. Right? So here before, right, we looked at the volume of breath, the amount of air you breathe in, right, during one cycle. We're going to use those kinds of volumes to get a sense for how your respiratory health is. So these will be things like tidal volume, okay, a couple of reserve volumes, so inspiratory reserve volume and expiratory reserve volume, and then finally residual volume at the very bottom. What do all these things mean? Well, focusing just on the volumes here for a second, this top part, tidal volume, this is the amount of air that you breathe in under a normal resting breath, right? So the average person breathes in about ½ liter of air, give or take, and they breathe it back out, right? But the tidal volume is simply how much comes in and back out, right? About ½ liter. The inspiratory reserve volume, okay? This is the amount of air that you can breathe in after a normal breath, okay? So if you were to take the biggest breath you possibly could, right? And then think about the additional, the difference between that and the tidal volume, right? The difference between those two things is going to be the inspiratory reserve volume. The expiratory reserve volume is somewhat similar, right? You breathe in, normal resting breath, you breathe back out, and you're done. And then you continue to blow out, okay? That's the expiratory reserve volume, the amount of air that you can continue to exhale, right, beyond the normal tidal breath. Now, usually we have a fairly large IRV, right? It's typically larger in males than females. Men typically have a larger rib cage, which is why this is a bigger difference here. And a somewhat smaller ERV, but again, males typically larger rib cage have a larger expiratory reserve volume. The residual volume is the amount of air that never leaves, okay? And we'll see in a little bit, there's a couple of good reasons why there's residual volume that never actually ever gets out of there. It's basically stale air that is always being sort of remixed with fresh air. And in males and females, this is usually about the same. It's a little over a liter. Now, going beyond those simple numbers, we can also talk about respiratory capacities, okay? And these are going to be combinations of the volumes, right? So we're going to use this set of things, right, these separate volumes, to give us respiratory capacities. And these will be things like inspiratory capacity, functional residual capacity, vital capacity, and total lung capacity. So to think about how all these things fit together, okay, here we have a spirograph. It happens to be a male, doesn't make real difference. It's just trying to match the volumes up to what it is. And here we've got a normal tidal breath, right? Resting breath in, resting breath out, about 500 milliliters, okay? Now we ask this guy to take a massive inward breath, a forced inspiration. We get this kind of volume, right? The inspiratory reserve volume is all of this, right? Everything above and beyond the normal tidal breath. Then we have him blow all the way out, right? Get as much air out of his lungs as he possibly can. That's this, right? The expiratory reserve volume, below that tidal volume. And then everything that's left, right? This is that residual volume, okay? Now we're going to take these 4 volumes and give us some capacities. So tidal volume and inspiratory reserve volume, right? Together, this is the total amount of air that you can breathe in. So that's the inspiratory capacity, all right? Now the total amount of air that you can exchange, so you breathe in as deep as you can and you blow out as deep as you can, that total amount of air that you can actually move in and out of your lungs, okay? That's the vital capacity. So the IRV, tidal volume, and ERV. We take vital capacity and we add the residual volume, then we get the total volume of your lung, right? The total lung capacity. And then if we want to take the ERV and the RV and add those together, that's the functional residual capacity. This is the amount of air that on an average breath, you actually don't exchange, right? Somewhere around 2.5 liters of air in your lung sits there under normal breath conditions, not leaving, just hanging out. So one of the reasons that we've got residual volume here, right, is that we've got what's called dead space. And dead space is just anything that doesn't contribute to gas exchange, right? And some of this is going to be anatomical, right? So about 150 mils is what we'll call anatomical dead space. And that's just the air that's left in the passageways, right? You breathe all the way out, there's still air in your bronchi. There's still air in your bronchioles. There's still air in all of the lobar and all that, okay, that you can't get out, right? So that's the anatomical dead space. Beyond that, we've also got what's called alveolar dead space. And this is alveolar space or alveoli that are blocked off, right? They don't work, right? So there might be mucus in the way, they might have collapsed, whatever, okay? We can take anatomical dead space and alveolar dead space, add them together. That's our total dead space. And that's a fairly large component of what this residual volume ends up being. What we saw before, right, on this particular little graph here, is one of our basic pulmonary function tests called a spirometer or spirometry. And it's basically just a tube that you breathe into, and it measures the respiratory volumes. Right? It's all very, very easy. One of the reasons that we use spirometry is that it can help us distinguish between a couple of different kinds of problems when someone's having some respiratory issues. It can distinguish between obstructive pulmonary disease, things like COPD, right, or bronchitis, or restrictive disorders where we've lost total lung capacity because of disease, okay, pneumonia, stuff like that, or fibrosis. The way that we're going to distinguish between those two is that we're going to see different numbers, right? Total lung capacity tends to increase with OPDs. It tends to decrease with restrictive disorders. Vital capacity, functional reserve capacity, residual volume, all these things get smaller with restrictive disorders. They tend to increase with obstructive disorders. We can also try to think about rate of movement, how much air can you move in a given amount of time. And so we can talk about, say, forced vital capacity and forced expiratory volume. Forced vital capacity is that gas forcibly expelled, right? And when they take that to a forced expiratory volume, here we're going to look at specific time intervals. Okay, so over a minute, over 2 minutes, whatever. The easiest way for us to look at this, and what we're really getting into here is it's called alveolar ventilation, is what's called minute ventilation. And we're just going to hook you up to a spirometer, and we're going to say breathe for a minute. Right? And we're going to see what the total amount of air that goes into or out of that respiratory tract in that minute. Normally at rest, right, you're going to move about 6 liters per minute. Right? Now you take somewhere around at rest, say 20 breaths per minute, about 5 seconds a breath, about half a liter per minute, or half liter per breath, gives us 6 liters per minute. Okay? But if we start hyperventilating, right, or with exercise, we can get up to maybe 200 liters per minute. So there's a very large room for expansion here. It's easy to get. It's a very simple measurement to make, but it's a really, really rough estimate of respiratory efficiency. So on the next video, then, we're going to go ahead and continue on and finish off the respiratory system. We'll talk about, all kinds of things, particularly the gas exchange itself and how we transport gases in the blood.